I really like talking to this group because you guys always seem to be so well informed. And so what I thought I would be doing tonight, instead of going through like a whole bunch of studies and why we pick drug A or versus drug B, is really maybe to try to focus on sort of the underlying concepts behind what we do, at least from a medical oncology standpoint. And I hopefully I won't lose people along the way, but at any point, if you guys have questions, something you want me to elaborate on, feel free to interrupt me, or you can send a message. I'm happy to be interrupted. So, so the title of my talk is Hormone Therapy for Prostate Cancer, Past, Present, and Future. So I want to start off just giving a little bit of background about someone named Charles Huggins. This was his obituary, which came out actually right around the time I was finishing my fellowship in 1997. And he made an observation way back in 1941 that if you took men who had advanced prostate cancer and you remove testosterone from the system, mainly by removing the testicles, that you would get these very dramatic responses. And this was, at the time, incredible. And no one really understood exactly what was going on. This predated chemotherapy by a good 5 to 10 years. And so it was really this outstanding thing where prior to this, the only way to treat cancer was with surgery or with radiation. And here, even though it was surgery, the concept behind it was medically driven. And so that was really the foundation of testosterone and the manipulation of testosterone in prostate cancer, which continues, 80 years later, is still the backbone of what we do from a medical standpoint for prostate cancer. So from this initial observation, really a whole set of questions came. I'm not sure how to advance this. I guess it's under my control. There we go. So there's a few observations. The first, of course, which I just mentioned, is that prostate cancer seems to at least temporarily go away when the body's deprived of testosterone. And so really this brings up a whole series of questions, and only some of which I've outlined here. The first is, what is testosterone in the first place? And where is it made? How is it made? How does it work? I mean, is it some magical thing, or there must be some underpinnings behind it? And then why is this benefit of testosterone only temporary? And then how can we use all of this knowledge about testosterone to start actually designing effective treatments instead of just bumping into random observations? If you really know what's going on, then you have so much more power to invent and discover tools that you can use to help control the disease. So on the top of this slide is what is the chemical structure of testosterone. It's a multi-ringed compound. It's a hormone. And that's up on the upper left. Actually, testosterone is actually not the most active thing in terms of the male androgens. It's really something closely related called dihydrotestosterone. The only difference is that if you look in that ring all the way to the left, there's two lines near the bottom. That's called a double bond. And that's a single bond in dihydrotestosterone. But dihydrotestosterone is at least 30 times more powerful than testosterone. So really inside cells, even though we talk about testosterone, it's really dihydrotestosterone that does most of the work. And there's an enzyme that converts testosterone to dihydrotestosterone. It's called 5-alpha reductase. Some people may have heard of it, some not. But there are some drugs that block that with some interesting effects. Many people probably have heard of finasteride. It's also called Proscar, and that helps shrink prostates down. The other drug that's also phenasterone is something called Propecia, and that is a drug that you can use, men use, and by blocking dihydrotestosterone synthesis, you can help slow down or prevent male pattern baldness. So that's become a very popular drug, just as an aside. So just to show how powerful it is when you know this, these mechanisms, what you can do. In any case, about 90% of testosterone is made by the testis, which you see in the lower left, and about 10% is made by two organs. One's the adrenal gland, and the other depicted there is actually prostate cancer cells themselves. They often develop the ability to make their own testosterone, sort of to feed themselves. I won't go into how testosterone synthesis is controlled in the adrenal or the prostate cells, but it's very important to understand how testosterone is made by the testis. The testis typically will just sit there and not make any testosterone unless it's told to do so. And the place where it's told to do so is the brain. And so there's a signal from the hypothalamus, which is part of the brain, and that's called GnRH, is the name of this hormone. And that tells the pituitary gland to make something called LH. And LH is a hormone that then travels through the bloodstream down to the testicles and tells the testicles to make testosterone. And as the testosterone levels rise, there's this thing called the feedback, where then it tells the hypothalamus and the pituitary to slow down and stop making too much testosterone. And so, as you'll see in some subsequent slides, this information is used to try to figure out effective ways of keeping the testosterone from being made by the testicles. On to the next slide. So a little bit about how testosterone is made. It's actually made from cholesterol, which, unless you know much biochemistry, you'd be surprised to know that they're even related, but they're actually closely related. The only purpose of showing this slide isn't really to know all these intermediate steps, except there are, but that cholesterol can ultimately make several things. In the middle, you see in blue something called cortisol. That's made by the adrenal gland, which I'll get back to in a few minutes. And over on the right is testosterone. So that's the final product from cholesterol in this pathway. And then actually estradiol, which is the main female hormone, is very closely related to testosterone, is actually made from it. So all of these drugs, I mean, not drugs, all of these hormones are closely related structurally, even though they have vastly different effects on the body. The body uses the same kind of similar processes over and over in multiple different ways to get different effects. So how does testosterone work? So I have here is a pictorial, and what this is a blow up of a single cell. It could be almost any cell, but we'll say it's a prostate cancer cell. And the central part is the nucleus. The nucleus is where you hold all your DNA, and all the genes are located there. And then the cytoplasm is that outer part in white. So the way testosterone works is it needs a helper inside the cell to do anything. You could dump testosterone on prostate cancer cells and absolutely nothing would happen unless you had this other protein, and this protein is called the androgen receptor. And so this is a pictorial of the androgen receptor, which is really the key to how testosterone works. And so it's a fairly long protein. It has this, on the left, there's this squiggly area. That's called the N-terminal side. All proteins have what's called an N-terminal and a C-terminal. The N-terminal is basically the left-hand side, the first part that's made, and the C is the other end. There's a green part in the middle, and the green part is the part that can stick to DNA and turn genes on and turn genes off. And then this big purple part is the part that testosterone or dihydrotestosterone will stick to. And when it sticks to this purple area, it changes the shape of the molecule so that a lot of things start to happen. When the shape of the molecule changes, it's called activated. And when it gets activated, two of these proteins come together to form a duet of two proteins. We call it a dimer. And then it only in the dimer form does it then travel to the nucleus. And when it gets to the nucleus, then it turns on certain genes and turns off certain genes. And that leads to cell growth and cell division. And so this whole process is really the key to how testosterone works. I guess any questions at this point? Things that don't make sense, or is everything pretty clear to people?
I don't have any messages in the chat or questions.
Okay. So this is just another pictorial adding just a couple other sort of features to this whole thing. On the left-hand side is pretty much exactly what I told you. You can see this T, which is peach colored, turns into DHT, which is the dihydrotestosterone, and that binds to the androgen receptor, which in this is depicted as green. Then they form this dimer, and then it goes to the nucleus and then turns certain genes on that are involved in growth and survival. And I'll get back to this later, but there's a whole other part that of the androgen receptor that can get turned on even if there's no testosterone around. And this was more recently known. And this is through a pathway called PI3 kinase pathway or AKT pathway. It wasn't really appreciated how important this was, but when we talk about sort of the future of hormone therapy, you'll see that this other pathway to turn on androgen receptor is also an important thing to know so that we can target other drugs as well. So really, it's not testosterone that's doing all the work. It's really the androgen receptor that's doing all the work. And testosterone is just a means by which you take this protein and turn it from the off position to the on position. So what have been with all this knowledge, what sort of has been the hormone treatment strategy for prostate cancer? Well, before 1985, because we didn't really know a whole lot, the only thing we knew is, well, we could just surgically take out the testicles, and by that way, you reduce the testosterone. You reduce the testosterone, now the androgen receptor can't really work, and you get the result that had been observed way back in 1941. After 1985, we really started to produce medications that really started to take advantage of this growing knowledge to block androgen receptor. So the first was to use medicines to block the body's ability to produce testosterone. I'll talk about more of that in a minute. And the second is completely bypass testosterone and actually start to medically block the androgen receptor itself. And if you can do that, then you can also block all of those same functions. So that was really the basis of most everything that has happened since 1985, is really just focusing on these two key things. So in terms of agents that block testicular function, these are probably going to be familiar to many of you. And essentially, all of these drugs do the same thing, which is they block this signal that the hypothalamus sends to the pituitary of this GnRH. And by blocking it, then the pituitary can't send out a signal to the testicles. And if that happens, then the testicles just sit there and do nothing. And so this is a way of what we call medical castration. So I'm sure you've heard of leuprolide, triptorelin, and then there's some more recent ones, degarelix and relugolix, which is an oral drug. But basically, they all are doing the same thing at the same place in the body. Very, very slight nuances, but essentially, this is how these drugs work. One of the key things to note, though, is that this only affects the testosterone that the testicles make. That little bit of testosterone that the adrenal glands make, as I said before, doesn't affect that one bit. And any testosterone that the prostate cancer cells make will just keep making it. So obviously, this is only partially blocking testosterone. And this is why when you go on these drugs, you still have often testosterone levels of 15, 20, 25. It doesn't go down into the single digits or lower with some of the newer strategies. Another means of blocking the testosterone from being made is completely not worrying about whether it's made in the testicles or not, but understanding that pathway I told you about where cholesterol gets converted to testosterone. And so there's some key enzymes. The enzymes are things that make it easier to get from one chemical to the next. And usually the body can't make chemicals unless it has these enzymes to make it all happen. And so there's a key enzyme called CYP17. And there's a drug that's been developed that many of you probably heard of, and it's called abiraterone or Zytiga. And what it does is it blocks multiple places in the pathway. So now cholesterol can't make all those things that are after the blue circles. So it can't make, the body can't make cortisol anymore, and it can't make testosterone or DHT, which is the dihydrotestosterone. And again, completely different way of blocking testosterone synthesis. But one advantage is it not only blocks anything that the testicle might be making, but it also blocks any testosterone that the adrenal gland makes, and also would block any testosterone that the prostate cancer cells themselves make. So it's a much broader way of blocking testosterone. And this is why when you have patients who are on this drug, you do expect testosterone levels to be extremely low. Typically, single digits is very common.
Dr. Mannion, I have a few questions.
Sure.
Will reducing cholesterol reduce testosterone?
Probably not, because you don't need much cholesterol to make these pathways go. So even if you could cut your cholesterol by 50%, there's still going to be plenty of cholesterol around to make testosterone. So that would probably not be really a good strategy to lower the testosterone levels.
Okay, and I have, what function does the androgen receptor play when it's not modified by testosterone or dihydrotestosterone?
Well, it's sort of sitting there and waiting. Basically, think of it like an antenna, an internal antenna that's kind of waiting to hear a signal to tell it to do something. So I guess it would be kind of like a radio tower waiting for, or radio waiting for radio waves to hit it. So the radio just kind of sits there. It doesn't make any noises until the radio waves hit it, and then it suddenly turns on and wakes up. It's kind of like that.
All right, and one more. If kidneys are making testosterone, why do levels go zero to zero after the RP?
So I think you mean the PSA goes to zero after RP, because testosterone levels don't drop after a prostatectomy. Unless I understood the question wrong.
Said my mistake.
But it is true that the PSA does go to 0 after prostatectomy, but PSA is a completely different thing than testosterone.
Okay, and then I lied. One more.
Sure.
Would it be possible to eliminate the androgen receptor as a treatment?
So obviously someone's been looking ahead, because that is a strategy that makes a whole lot of sense. And there's a lot of drugs actually being developed to try to destroy the androgen receptor or degrade it, so as another means of trying to keep it from functioning. So that's a very very good question, but we'll answer that a little bit later in the talk. Anything else?
Nope, you're good.
Okay. All right. So the second way, as I said, is to design drugs that don't really affect testosterone, but really start to try to work on somehow keeping the androgen receptor from doing what it's supposed to do. And so there's a whole family of androgen receptors that have been developed. There was a first generation, and these are what are considered older drugs at this point: flutamide, dichlutamide, although they're still used some today. And then second generation, which are used very commonly now, enzalutamide, apalutamide, darolutamide are the ones that are on the market. And so all of these do basically the same thing, which is block the androgen receptor from working. And so it does it at multiple levels. And so this is a pictorial on the left of just the example of enzalutamide, but essentially the same thing would be for apalutamide and darolutamide. So the first is that it does block or make it very difficult for testosterone to actually bind to the androgen receptor. Remember that purple part? And if you can't do that, then the androgen receptor won't get turned on. The second, even if it does get turned on, it does block or partially block the androgen receptor's ability to then move to the nucleus. And if it can't get to the nucleus, then it can't turn those genes on. And the third is that even if it gets into the nucleus, and even if it sticks to the DNA, there's one other step that I didn't talk about, but there is a final step before it can then actually turn on genes. There's more proteins that come in and stick to the androgen receptor, and these are called coactivators, and this happens in the nucleus, and it blocks that. So it actually blocks it at 3 different levels. And so these drugs, of course, have become very, very popular, and they're used, at least in advanced prostate cancer, on a regular basis at this point. They all have slightly different side effects and slightly different features, but essentially they're all drugs that are in the same family that work in essentially the same manner. So in terms of the development of these drugs, most of this is really a modern phenomenon, and almost all of this work has really not hit the clinic until the last 10 or 15 years. Certainly Lupron, which is sort of the very first medical treatment for hormone sensitive prostate cancer, that was developed in 1985, and we really didn't have anything until 2008, which basically was just a variation of the same thing. And so it really wasn't until 2011, with the approval of abiraterone, that we finally got beyond just simple blocking testosterone synthesis by the testicles. And that study showed, or that and a series of other studies showed, that you can control the cancer longer, you can live longer. Almost every endpoint that you look at, people do better when you do blocking both testicular synthesis and then just the testosterone synthesis itself by these other organs. And then soon thereafter, this is when the androgen receptor blockers all came to market and really showed almost the exact same kind of benefit. And again, multiple trials in multiple different situations, all showing the same thing, is that these drugs do work and they do make a difference. It's not just theoretical. And so that really brings us to today. And as I said, there's just a laundry list of studies that all show a benefit of all of these. So what I was going to do after this is really move on to kind of, well, what's the future? Because this is kind of where we are at the moment. But before I do that, I'm happy to answer any questions about kind of how are these drugs used today? What scenarios we use them, before I move on.
Yeah. Hi, Dr. Mannion. I have a question. I don't know if you can hear me.
Yes.
Hi, this is Ethan Bouguet. First of all, thank you very much for being with us tonight. Sorry I was late entering. I had some internet problems. I actually was speaking with a good friend who's been on abiraterone for several years, and suddenly his PSA popped up by a lot, from like 0.0 something to 0.7 in a space of months. And he thinks that maybe abiraterone has stopped working. And he's wondering why that suddenly happened, and why there would be such a flare in his PSA level. But he was using, I think he was with his oncologist, he was experimenting with an estrogen, using something like an estrogen therapy. And I noticed in one of your previous slides, it said that one of the androgen receptor variants could make the androgen receptor have estrogen bind to the androgen receptor and activate it. And I was wondering, would that be a possible reason for his PSA to go up all of a sudden in the space of months?
Yeah. So I was actually going to get to what's called, how do the prostate cancer cells become resistant to these current therapies? But I'll try to answer some of that. So there are multiple reasons why abiraterone may suddenly stop working. It's probably not because the testosterone levels suddenly start going up, like there's a change in how testosterone is made that bypasses the abiraterone blockage. But it's probably much more at the level of the androgen receptor, where something changes about the androgen receptor so that now it doesn't really need testosterone anymore, or some variation thereof. And so there's a whole host of things that can happen. One is that the cell can just start making much more of the androgen receptor, so that even tiny bits of testosterone are enough to turn it on. So that's called androgen receptor overexpression. So that's one method. A second possibility is, as you alluded to, sometimes the receptor changes its structure so that now things that normally don't turn it on, that are not too different from testosterone, for example, progesterone or cortisol or estrogen, which normally don't turn on the androgen receptor, now do, because the androgen receptor has a couple of mutations that now make it turned on by the different hormones. And so is it possible that the estrogen is driving it? Possibly. And then sometimes things can happen to the androgen receptor, again, which I'll talk a little bit more about in a minute, where the receptor gets turned on autonomously, where there's no more regulation. It's permanently stuck in the on position, no matter how much or how little hormones around. And that's another form of resistance. So it's a vigorous area of research, because if you can understand why resistance develops, then of course you can develop drugs to try to counteract that. But you first have to understand the problem. So those would be the things that would go through my mind in terms of the why. Why did abiraterone stop working?
All right, thank you.
I have a question. I'm currently taking abiraterone, which I started in 2017. It's a very expensive drug, but luckily I have Medicare. My PSA is maybe 2 or 3 times a year 0.01, and the other 9 or 10 times it's less than 0.01, there hasn't been any significant rise. Is there any reason why I would want to switch to enzalutamide or apalutamide or darolutamide?
No, I mean, I would say you're doing incredibly well, and there would be no reason that we know of at this point to switch. I mean, theoretically, you could argue, well, I should switch now before some resistance develops, but almost anything you pick, it's still going to potentially drive resistance at some point. So I see absolutely no reason to change what you're doing.
Okay.
All right, great. So I'll move on. So as I said, the next thing is really what's the future, and to understand the future, you have to understand why do these drugs fail? And so I've alluded to some of this already, but there's really 3 main general themes as to why these drugs stop working. The first, as I said, is that the cell just starts to make much, much more androgen receptor, 5-fold more, 10-fold more. And so now even traces of testosterone are enough to turn the androgen receptor on, because it just overwhelms the drug that's trying to block this. So it's kind of a brute force just by sheer numbers of androgen receptor. The second, which I kind of alluded to already, if you remember, there was the androgen receptor sometimes can get turned on by a method that's completely independent of testosterone. And this is where this alternative pathway of AKT primarily mediated turning on becomes important. And we'll talk about it later when they talk about some of the studies that we're now doing to turn the androgen receptor off by this means. And finally, the androgen receptor itself can mutate, where its features just subtly change. So now things that normally wouldn't turn it on now are turning it on. So I gave you the example before of estrogen normally doesn't turn it on, but with some mutations, it now does turn it on. There's cortisol, which is essential hormone that our adrenal glands make. Normally does not turn on the androgen receptor, but there's some forms where now it does turn it on. And then there's also been described mutations where, let's say if someone's on Casodex, or bicalutamide, which is a 1st generation androgen receptor blocker, which normally keeps it from being activated, which now turns it on. And that's the basis of doing what's called like Casodex withdrawal, where you stop the drug. And sometimes just by stopping the drug, now the PSA goes back down, at least for a while. So and there's over 600 different androgen receptor mutations that have been described. Now, some of them are very uncommon and some are more common, but these are ways that the receptor now gets around the normal inhibition. And on the next slide, I was just going to talk about some of the more common ones. So these are specific mutations. And so the nomenclature on the left, what the nomenclature is there's a 1-letter character that describes what amino acid. The proteins are made of amino acids. It's like a long bead on a string. And so like T877A means the normal T amino acid at bead number 877 is turned into an A. So it's just a single amino acid change. Now the androgen receptor, if you make that single change, it becomes totally resistant to enzalutamide, and it becomes activated by estrogen and by progesterone. So you can see how that mutation can really just suddenly change things dramatically. There's an L701H, and now cortisol or cortisone now activates the androgen receptor. And then I really want to talk a little bit about the last two, because these have gotten a lot of publicity. And this is the androgen receptor variant 7 and variant 567. And so if you remember that pictorial where there was this big purple part of the molecule, the big purple part where the testosterone binds to, well, in these mutations, imagine that same molecule, but the purple part is totally gone or almost totally gone. And so now there's no place for testosterone to even bind to, or any of the other hormones for that matter. And now this sort of truncated or partial androgen receptor, it's permanently turned on. And it just lives in the nucleus, and it's just turning on, and it's just making all these genes turn on, and there's no way to stop it. There's no way to turn it off. And so these are mutations that really predict complete resistance to hormone therapy. And so these are mutations that you really don't want to have, but they do exist. And V7, we can actually do blood tests now to detect that. We don't have one good one yet for V567. But these are just some of the more famous examples of mutations and why now our current therapies no longer work. So what's the future then? I mean, what are other strategies that we can do to try to overcome all the current therapies that we have? Well, we'll go back to the androgen receptor. And so there's two main strategies that are currently being used to try to keep the androgen receptor from working in ways that we don't do today. And so the first is the left-hand side of the androgen receptor. What if we design drugs that stick to that and block the androgen receptor by mucking up the works, so to speak, by something that sticks there? And so there's actually now what are called N-terminal domain binding agents. And these are in the EPI family. So there's EPI 506. Most of these all have numbers. These are all drugs. Another is EPI 7386. And so EPI 506 was developed probably around 2012, 2013. It seemed to work pretty well in early trials, but it caused really bad nausea. And so probably is not going to be a drug that comes to market. But EPI 7386, currently there are trials going on, and with early studies looking somewhat promising. The closest place that I'm aware of that offers that right now is WashU in St. Louis. So we'll see, but it's a strategy that is definitely being explored actively. The second, which was already alluded to by one of the questions, was, is there a way to just take this androgen receptor and destroy it, have the body break it down? And these are called androgen receptor degraders. And so there's been a lot of work in this area. And some of the examples here is galaterone. That's gotten to phase 2-3 trials. But so far, the data hasn't really gotten to the point where it's really good enough to get FDA approval. So right now they're working on sort of second generation drugs that are related to this compound. I'd say the one that's the most promising of these is this drug called ARV-110. It also has a name and not just a number, which is bavdegalutamide. Trying to pronounce it. Bavdegalutamide. And so this just completed a phase 1-2 trial that was just published this year. And these are all patients who have been heavily pretreated, who are castrate resistant. And there was about 60% of the patients who went on this drug did have a significant drop in their PSA. And so the company that's making this, I forget the name, They are starting to work with the FDA to start the process towards potential FDA approval. So I would say of the drugs on this slide, that's the one that's probably closest to getting approval. ARCC4, there's not a whole lot of data right now. And AZD 3514, again, phase 1 trials were a little bit disappointing, but there's other ones related to that AstraZeneca is continuing to work on. So I'd say, it's realistic that within the next 2 years, we might have our first AR degrader on the market, but we'll see. And again, that would be just another tool that we have as far as hormonal therapy.
Dr. Mannion, I have a question.
Sure.
Is LU-177 one of these test drugs?
No. So that's a completely different way of trying to kill cancer cells. So really, this talk I was focusing on sort of the hormone-based therapies, based on testosterone or androgen receptor. But obviously, that's a very promising approach as well. But that's really a form, I would call it a form of targeted radiation, where you have radiation attached to a target that will specifically just go to prostate cancer cells. These drugs that have, these compounds that have high affinity for PSMA, which is on most prostate cancer cells, and then you tag it with this radioactive material, and then the radioactive material then goes on to kill the cell. So it's another form of killing a cell, but it's completely unrelated to hormone manipulation. Let's see, other questions.
What is Nubeqa, and why is it considered to be a second-generation hormone therapy?
So Nubeqa is the darolutamide, which is one of those second generations. So the reason they call it second generation is it just binds to the androgen receptor much tighter than the first generation ones. And so they're just more powerful at blocking the androgen receptor than the first generation, the bicalutamide and the flutamides, which is why in the trials they seem to do a better job. But that's why they're called second generation.
Awesome. Thank you.
Okay. And then another alternative way is to block the androgen receptor, not through testosterone, but through this second pathway. This seems to be a pathway that may not be as important early on, but as cancer cells become resistant to hormone therapy, they rely more and more on this pathway to turn on the androgen receptor, this pathway on the left. And so now there are drugs that are being developed that block the AKT signaling pathway. And so here's a list of some of those drugs. And they seem to be particularly effective in cases that are P10 mutated. P10 is a brake on this whole pathway. And so if you release the brake, then this is a pathway that's going to be turned on more and more active in prostate cancer cells. So it seems like in that particular situation, these drugs might have their real niche. And so the first drug there, the ipatasertib, there was a trial last year that showed, at least in patients who had P10 mutations, which normally means they're more refractory to hormone therapy. They were now much more hormone sensitive when you combine that with abiraterone. And so now there's trials looking at that in more detail, and we'll see over time whether that gets FDA approved. But again, on this list, I think that's the one that's closest to potential FDA approval, although it may not be pertinent for all prostate cancer patients, but at least the P10 mutant subgroup. And then these other drugs, The second one, which is the AZT 5363, that trial is actually open in Indianapolis, where people are using that in combination with hormone therapies. There's no data yet, but that trial is open. And so that's really the future, at least as far as how we envision potentially blocking the androgen receptor in new novel ways. And we'll see, over the next 5 to 10 years, how many of these theoretical things will really come to fruition that we can use on a day-to-day basis. So that really concludes my talk. I hope this was informative to people. I hope you enjoyed it. I enjoyed preparing for it. I learned a couple things myself, so I think it's always good for all of us to review things, shed new light on things. So anyway, happy to answer questions related to my talk or just in prostate cancer in general. Happy to answer them as well.
Well, could I jump in? Can you hear me, Dr. Mannion?
I can.
Okay. So again, this is fascinating slides, and it really sheds a lot of light for those of us who really don't understand what the heck is going on inside our cells. But I think the part of it that mystifies me as an engineer is to try to understand what, if we were to dive into the cytosol and see all these androgen receptors, how many of them are actually floating around in any given cell? Are there 10 of them, 100 of them, 1,000 of them? And why are there so many? And how many genes do they actually have to activate? How many of these guys actually have to go into the nucleus and latch on to DNA to make our normal cells function? So can you give us some kind of sense of the numbers?
Yeah, so these are good questions and difficult questions to answer. So depending on the cell, obviously there's some cells that have very little or no androgen receptor and they don't really respond to testosterone. And there's some cells that have lots of the androgen receptor. And that's what makes cells different from one another, is that different things do different things to a cell depending on what's in the cell. So, I mean, if you're talking about a cell that's very sort of dependent on androgen receptor, it's probably high hundreds to low thousands of these in the cytosol. There has to be enough there to sense that there's testosterone in the environment. And so obviously not all of them are going to get turned on because there's not enough testosterone to turn all of them on, but all you need to do is turn a few of them on. I honestly don't know how many has to go to the nucleus to actually turn things on. I'd say that's not a well understood phenomenon. We don't know exactly, like, okay, testosterone binds to 1,000 androgen receptors, but how many of them actually finally get to the nucleus to do the final thing? I mean, there's probably things that happen along the way that these are simplified pictorials, not every single androgen receptor that gets turned on will make it to the nucleus, for example. So these are general phenomenon. And of course, we're always learning more and more all the time. You think you have it all down, and then you suddenly realize there's other components that you didn't consider. And so there's a lot of what's called positive regulation and negative regulation. And these pathways are usually much more complicated than these simple pictorials. But I think the themes are correct, because when you do the manipulations that predict certain results, you actually get those results.
Right.
Are the androgen receptors in all our cells or just prostate cells?
They're in all cells that respond to testosterone. So they're certainly not unique to prostate cancer cells. So, for example, remember I told at the very beginning, the hair follicles that in the presence of dihydrotestosterone, men often will lose hair. If if the hair follicles are very responsive to dihydrotestosterone. So obviously the hair follicle cells have androgen receptor. During sexual development, all of the things that change during puberty, those all have to have the androgen receptor so that they can carry out the function that testosterone is doing. So no, it's certainly not limited to prostate cancer.
I have a couple of questions here, Dr. Mannion. How do I know if my doctors are up to date on these medications without reading medical journals?
Probably the only way really is to ask them. Have you heard of this, or have you read about this? I mean, the problem with medicine is not so problem. The fact of medicine is that at least in medical oncology, it's changing really fast. And so unless you read and keep up, you become outdated pretty quickly. And there's no one grading you or anything. There's no place that says, or have you read this article or have you read that article? So there's a lot of variation in how knowledgeable people are. And that would be very difficult to ferret out without, I guess, direct questioning.
And then I have another question, off subject a little. A couple of years ago, we heard about a trial that involved Provenge and early stage prostate cancer. Have you heard about the results of the study?
So I'm not sure which study. I mean, I know there was a study where they were looking at people who were on active observation, and I think they were randomized to stay on active observation or go on Provenge. I think that study, to my knowledge, if it's the study that you're referring to, I think it's closed to accrual now, but there hasn't been anything reported or published that I'm aware of. So I'd say wait and see. Maybe in another year or two, we'll have some kind of data, but I'm pretty sure the study's closed at this point.
That's all the questions I have. Does anybody else have any questions they want to send or ask Dr. Mannion?
Okay, since before we lose you, because I think it's such a there's so many things that we as patients really should know about our disease, I suppose. But what hope is there for finding an alternative pathway to inhibit prostate cancer? I mean, we know that inhibiting testosterone has a lot of side effects. And is there any hope of finding some alternative way of controlling prostate cancer other than by reducing testosterone? And I actually have another question about that. We know that there are many side effects of ADT. One of them is its effect on the emotional state of the patient. And I'm wondering how aware oncologists are about this issue and whether you feel it's being addressed in a meaningful way. In other words, are patients who are about to undergo ADT, are they being told about these effects? And is there some kind of support system in place to mitigate some of these effects, or at least make them more tolerable?
So I'm not really aware of anything that's reproducible that's clearly helped that potential side effect. It's very variable, as I'm sure you probably know. Some people have none of that, what you described, and some people it's pretty significant. In terms of like short-term memory loss or feeling in a fog, we don't really understand it particularly well as to why it happens, significantly to one person and not another. I certainly try to always warn patients about that possibility. Again, I'm not aware of a specific support group or way to really deal with it in a very effective way, except if you can do it to do things like intermittent ADT therapy versus continuous, as long as it's an appropriate situation to do intermittent therapy. Obviously, that's one strategy. I don't think we really understand it very well. There's probably some androgen receptors in different portions of the brain that vary from person to person as to why this happens. So I don't know if that fully answers your question. As far as other pathways, there's a lot of research going on. I'm not aware of any other major pathway that would sort of be a sort of a killer app for this. But you never know. I mean, if you extrapolate to other diseases, there's some diseases that we thought we knew really, really well, and all of a sudden, you learn about a new pathway that really has dramatic effects. So I guess there's always hope for that.
I have another question. Do genetics play a role, such as being the BRCA2 positive?
Yes, so they play a role, at least in day-to-day treatment. If you have a BRCA2, BRCA1, or some of these other DNA repair genes, that PARP inhibitors can be quite effective if you carry one of those. So it's a strategy if you have one of those that can work actually quite well. Probably about 25% of men will have a mutation in their prostate cancer that will make them a candidate for that class of drugs.
Okay, I've got another one as long as I can take another minute of your time. This PI3K pathway through AKT and mTOR, this is we know that some men have this PTEN mutation. Is there some way to detect it? How would you know whether a person is really a candidate for these drugs? I guess there's another one that's been around for a while, everolimus, I think it's called. And that hasn't proven to be very effective from what I hear. So, but it's more, anyway, how would you know when to treat a person with one of these drugs?
So, I mean, right now there's nothing FDA approved for these PTEN lacking prostate cancers. So it's not something that we routinely do on a day-to-day basis in the clinic, because it doesn't change our decisions, at least today. So
Okay.
really, the only way to know, to my knowledge, is if you're part of a trial, and then they would do specific testing in a specific lab to look for these mutations. I'm not aware of a way to know outside of that setting, unless you're aware of something. But certainly, if any of these drugs came to FDA approval, then you would obviously have to have a way to test for this. Yes, the everolimus, that's been on the market for quite a while. I'm trying to remember, I think it was first approved for renal cell, but it's also used in breast cancer. But yeah, even though it blocks the mTOR pathway, the results with prostate cancer have been disappointing, and it's either it's not blocking it well enough, and these other ones, at least the ones that I have on the slide here, are more effective, or sometimes some of these drugs have multiple effects on the cell, and sometimes you think you know the pathway you're blocking, but you really don't. And and then it's acting in a slightly different way, and that's why it's one works and one doesn't. So, but yeah, it's not as simple as every mTOR inhibitor is going to be effective in every situation.
It sounds like the oncologist it's kind of a tough road to hoe, right? Not exactly knowing what you're doing with any individual patient, right? It's kind of like doing the best you can, and with the drugs that you have available, there's so are there any tools you can use to really try to be more specific, be more patient specific, what they call like this precision medicine, to try and guide these therapies a little bit better?
Well, certainly the example of the PARP inhibitors, that's very much guided by precision medicine. And you do get a fairly black and white answer from that, whether it's worth trying that class of drugs. So I'd say that's where precision medicine in prostate cancer has actually worked pretty well. I'd say an area that I would like to see happen, but it's probably just too confusing because there's so many mutations, is, remember I told you all those point mutations in the androgen receptor that, you know, if you have this mutation, now this will be, it'll be resistant to enzalutamide, but it may not be resistant to darolutamide, for example. And so it would be nice if we had a panel of those that we could run clinically, like in the clinic. So we could say, oh, you know, Mr. Jones, I looked at your androgen receptor. We think we know why you're resistant to enzalutamide, and this predicts that now the next best drug is going to be whatever. We don't have that, but it's not a stretch to think that we might not have that sometime soon. We probably wouldn't have it for all 600 mutations, but we might have it for, you know, the top 5 or something. But again, we don't have that right today. But that would be something that I would envision we could get and would make a difference in our decision making.
Okay. One last question about how all these things evolve, right? We're saying, okay, your cancer has been responsive to ADT for many years. And all of a sudden, it's not. But it's not really it, right? So what happened? I'm trying to understand it. So I mean, when we're talking about probably billions of cells, right, in any given tumor, and so just process of random selection. In other words, ADT has, or whatever therapy has killed off almost all of these cells, but a few of them survive just because by chance they've mutated in a way that allows them to survive. Is that basically how it works? It's not like this cancer is really smart. It's just a process.
It's just a process. So you have to understand that all cancers, and prostate cancer included, the DNA is inherently unstable. And so a normal cell will be very, very good at reproducing its DNA and not making any mistakes. So the spontaneous mutation rate is very low. Whereas in a cancer cell, the spontaneous mutation rate is rather high. So if you were to sort of query the prostate cancer in time, over time, you see the DNA is changing all the time. And so you can imagine that you have these cells that are in the milieu of, you know, lack of testosterone. So of course, as all these mutations are happening, there's random mutations happening in the androgen receptor, most of which don't lead the cell anywhere, but you only need a couple of mutations that suddenly, oh, yeah, I don't need testosterone anymore. And those are the cells that gradually become the dominant cell because they have a survival advantage, not because they're smart, just by chance. It's sort of evolution, but in a much more accelerated fashion.
There you go. Okay, thank you.
All right, well, again, I really enjoyed it, and I really like your questions. I think shows you guys are really paying attention and are really curious. So I really enjoyed it, and thank you so much for listening.
Thank you for being here.
Thank you so much for being here, Dr. Mannion.
You're welcome.
Thank you everyone for coming.